Okay, our last talk, these have been really great talks, by the way. Our last talk is going to be by Dr. Srinivasan Vijayakumar. Dr. Vijayakumar, another University of Chicago person in the house. Wow, that's awesome. And he's going to be talking about osteosarcoma and precision radiotherapy. That would, Dr. Kumar.
I will try. It's going to be actually more of a, I'm using a case report to go to a space where some new breakthroughs could happen in osteosarcoma. And also, radio immunomodulation. And I'm glad there are so many experts from hearing those talks who probably are, like leaps and bounds better than me. And we can put our heads together to do something better, okay? So these are all my colleagues. I was at the University of Mississippi Medical Center for 17 years. That was a great team. It was really an interdisciplinary care, and I want to thank all of them, and the patient and the family. So you all know that great progress in outcomes has been made, achieved over the 50 years, limb sparing, use of neoadjuvant chemotherapy, and organ preservation, and whatnot. Overall survival, but there is nothing that has really improved in the past 20, 30 years. So that's kind of sad. And the outcomes have plateaued. The important poor prognostic factors are large tumors, less than 30% necrosis at neoadjuvant chemotherapy, metastatic disease, a short disease-free survival, and also local recurrence. Those are very important aspects. So the historical inflection point was 1970s, early 1980s, landmark approach, you don't need any more amputation. Just imagine young adults and adolescents and, little older children having to end up with amputation. That was, I've included some very remarkable landmark papers at the bottom. So the second one, of course, was, as I said, limb salvage versus amputation giving equally good results. But look at the overall survival at that time, 55% overall. And that had improved over the next 20 years. And then this was an European study where they showed that you don't need, multiple agents, but we give 3 agents as a neoadjuvant standard in the United States now. And the rule of thumb is, you need more than 90% necrosis index to have good prognosis. And this was again shown in a SEER data at the population level that between 1984 and 2000, actually since late 1980s, the survival hasn't really moved up. Modern era summary plateau since this was published in 2021. Again, the same point. Despite use of some of the immunomodulatory agents and concepts. So metastatic disease, as I said, is bad. So about 10 to 15% present with metastatic disease, and lung mets are really bad, and that's a common involvement. And overall, it's like 60 to 70% if it is localized survival versus 20 to 30% with metastatic disease. So again, this is, as I said, 70 versus 30, 60 versus 20. That's the range, you know. So this is 2025. Again, SEER data, age 5 to 29, extremity sarcomas, including neoadjuvant use. Interestingly, in this particular study, neoadjuvant didn't make a difference, but that hasn't yet been confirmed by an independent study. As I said, this is a SEER, and when you have a SEER data, you know, you need more robust data before we change our practice. That's at least my opinion, who doesn't actually give chemotherapy. So, yeah. So, relapse is persistently poor prognosis as a systematic review. So that's an important point. So there are about 5, 6 very important poor prognostic factors. The reason I went through all these poor prognostic factors for 2 reasons. One, this is the group we need to do new innovations. 2, my patient I'm going to present had most of them. And the first diagnosis was made in 2016 and still alive. So that's I'm a teaser. This is the teaser here, okay? So recap, significant improvements were made. I mean, we did good, but we are not improving it, okay? Almost more than quarter of a century. So what are bad things? Initial metastatic disease, less than 90% necrosis with neoadjuvant chemotherapy, locally recurrent tumor, large tumor, short interval time between first surgery and first recurrence, local or metastatic. And what I didn't show any data is axial and pelvic disease, because it's so difficult to operate and get every cell out. So we need some out-of-the-box innovation. Let's be that blue jet going away in innovation. So I will show you this extraordinary case. What are the clinical strategies and tactics? And it was remarkable because there are so many. You saw that collage of my colleagues. It was a great collaborative effort. I actually was Johnny-come-lately in the care. So it was a 24-year-old Hispanic male working for a major industry, showed up with a left elbow mass, and he had a biopsy, and it showed out to be telangiectatic variant of the left ulna. And this is a quick timeline from July 2016, and then he had the neoadjuvant chemo. Can you see the? Yeah, you all see this? Oh, you don't? Okay. So then he had neoadjuvant. He didn't have any good response at all. I'll show the pathological slide. Then he was an smart guy. He said, I didn't have any chemo response. Why do you want to give me the same chemo and get me into toxicity? He said no. Within 3 months, he had lung mets. And we said, let's give chemo. I used to go to all the PETs. I treated the PETs with radiotherapy. I had a name by my pediatric oncology group. Here comes the non-radiation oncologist. Because I would resist to give radiotherapy with all means, because my first training started in 1979, and I know what damage we can do. That doesn't mean we don't use it. And I'm so glad the techniques of radiation therapy have improved leaps and bounds. This morning there are two extremely good presentations. How we are able to give a high quality life with good results by using a judicious use of radiotherapy is important. That's one of the lessons from this, hopefully from. And then after a year at PET CT, it was spreading more. And then our thoracic surgeon, nice bilateral, 13 lesions were removed. Okay, did good. Still said no chemo. Then he had bilateral adrenal tumors, and he had them removed. And then by the time cabozantinib results have started coming out, he agreed for that, no chemo. And then I did well. And then he had a right adrenal ex-tumor bed recurrence at the crevices of where the diaphragm and the vertebral body meet and the liver is. I'll show the pictures. And then what we did, that's when I was called in by my surgical oncology colleague. So we treated with SBRT techniques and gave SABR doses, 800 times 5, big doses, 3 cm, with all the tricks. We did the image fusion with PET. We made him a whole body cast so that his breathing is, and then we did treat him with breath hold so that it stops, and we use the respiratory, And I worked very closely with Shannon, our surgical oncologist. Usually surgeons wait for 6 weeks. I told Shannon, we need to operate at 4th week, because if you wait for 6 weeks, there will be too much fibrosis. I know you may not like it, let's do it. It turned out to be about 5 weeks. So I scrubbed in. We also got consent before treatment for IVRT. We had IVRT capability at that time. We did breast IVRTs. So I scrubbed in. He was standing operating on the right side of the patient. I'm just here. Then he says, turns, BJ, what did you do? I was like nervous. Oh my God, I screwed up something. He said, it's liquid, man. I'll show the pathology. That was, well, we wanted it to be that way, okay? Because osteosarcoma is considered radioresistant. But I had worked at the University of Chicago, and I worked in Dr. Bexabaum's lab. So we had all these curves. If you give big enough dose, we beat that curve. We kill them. So that was the whole idea, and to operate quick enough. And then I gave IVRT to the tumor bed, and then we continued. So that's kind of this table, because busy table I explained. So I won't go over the details of that. The latest 2 weeks ago, he has a left adrenal tumor bed recurrence. Not in the right side, left. I have theory on it, but it's one case. You can't make.
Can you go back one slide?
Yes. Yeah. Okay. So this was the original plain films, big one. Here is the MRI. I'll go through them fast. This is the original biopsy, osteosarcoma. So we did the metastatic workup, no mets, 2 cycles of MAP, and then he had surgery in November. This is the response to neoadjuvant chemotherapy, not much. And then within 3 months, he had lung mets, as I said. Here are the lung mets lesions with 2 different ways. He refused chemo. This was a year after all those bilateral lung lesions in PET-CT. And then this is a lung pathology. I'm showing this pathology slide for a specific purpose. You will see it soon. And then this was August. He continued on, we started him on cabazantinib, and here he required bilateral adrenals. No, we haven't started it. This is when we started. He had bilateral adrenals. Then we wanted to shrink it, and when we did that, it shrank to some extent, partial response. Then we took that out. That's when my friend surgical oncologist got involved. So we had orthopedic oncologist, thoracic oncologist, then surgical oncologist, of course pediatric oncology, and then my medical physicist, radon, you just name it, and medical, although he was adult, he was treated actually by PDONC people. And then this is the adrenal. And then he recurred, look at that corner out there. This is what I was, here is the liver. For my surgical oncologist to go out and take it out would have been extremely difficult, would have left a lot of microscopic disease. So we went with pre-op, and we did, this is the microscopic. So what we did, as I said, it was liquefied, and after that, we looked at the PET. There are not any tumor cells. And the hemorrhage and hyalinization and all that. So the recent March, they are discussing how to treat him now. So that's kind of single case. So what's my hypothesis? He shouldn't be living. Although, I should say, his tumor did behave a little different. After lung mets, initially, he was almost 1 year. It did spread, but not like boom spread. You know what I mean? So, and after lung, he took another 2 years, although before it became another. So it does seem to behave differently. But what are the factors that helped him, to me? Extremely interdisciplinary. I'm saying interdisciplinary, it's not just multidisciplinary, because we got all our medical physics and who else not involved, okay? And willingness to do metastatectomy, 13 lesions removed, and also listen to the patient. He didn't want chemo, so we kind of dialed up the surveillance sequencing, and he was working, good quality of life all through. And the only symptom he got was diarrhea for cabazantinib, and we went from 40 milligram to 30 milligram. That kind of helped. And then using new target agent as soon, within few months after it was FDA approved, actually.
Was he, so one quick question. Was
Yeah.
he symptomatic, like from adrenal insufficiency standpoint?
No, we started giving him.
He was, yeah.
Yes,
physiologic
immediately.
and
Yeah.
fine.
Yeah, we gave cortisone and all.
Yeah.
See, that's why I'm saying endocrinologists were involved. Yeah. I didn't go. We just submitted the paper. I was waiting long enough. I didn't want to. I put everything together 6 years ago
Right.
because I would forget. I put all the figures and everything, but I didn't want to get it out premature. So Traditionally, osteosarcoma cells are considered real. It's used usually in the mandible after they do surgery and the pelvis and things like that, okay? And the doses, usually the way we treat, you all know that in radiation, got 2 gray fraction because it gets to, am I okay with time? Yeah. Normal tissue toxicity, but with limited dose, we can, with the SBRT and all the things we are able to do. I remember, in my first training in India, we had a machine called Janus. Janus is the Greek god of 2 heads. So they had something called the cobalt machines. You know the cobalt machine. In those days, the cobalt sources were very expensive. So what we had, it was actually designed by one of the radiation oncologists at Harvard University. He traveled all over the country, all world and helped. So, and once there are 2 identical twin rooms where we can treat the patient. It was so busy, right, in India population. So one set of technology will set one patient and treat. Meanwhile, somebody will be ready and they'll pull. This source will go from here to there. That's why it's called Janus. Then you treat that. Meanwhile, another patient would be ready, so that the efficiency was good. But you should see, in cervix patient, because it didn't have enough penetration like modern machines. If you treat cervix patient, we treat it from in front and behind. The machine doesn't go behind. So you have to treat the lady with cervix cancer, treat like this, and they have to turn over and treat. You feel the abdomen is like hot. Now, you don't see that. We used to see all that, right? I know how bad radiation can be. Anyway, so we did all this, as I said, 4D CT simulation, rigid immobilization, image fusion, breath holding, whatnot. Small volume. See, I just compared here the adrenal gland with all the tumors versus dead cells. Same thing, same kind of slide. So, and as I said, there's a lot of beautiful history about cabozantinib. And anyway, I won't go through this, I think kind of late. So, the potential benefits were hypothesized between 2016 and 2018. We started using it 2020. And then, see, this is what I want. A rad is not a rad is not a rad. Because it's not the machine. I call it, it's not the hardware, you stupid, it's the software. In the software, I tell my residents a double meaning. One is, the softwares have improved so that we can do a lot of very neat things. But it's also software of how the physicians and medical physicists and dosimetrists work together. It's like, it's a complicated, the chance to make an error is extremely high. The quality assurance, I tell you, has to be extreme. Anyway, so concurrent and post radiotherapy use of radiobiological agents and what I call radio immunomodulation. Why am I saying that? This was a paper I published, and I think I'm the only first one to coin the word radiobiotherapy. See, we all use chemoradiotherapy, but now we use all kinds of biological agents. But sometimes they are good. For example, cabozantinib has recall phenomena. In other words, it's just like adriamycin. You wait for some more time, you can get a recall phenomenon. So the good news is they seem to be working together. The bad news is you have to watch out for things. That's why we need a new biological concept where we we have to think very carefully when we give targeted agents, chemo and radio all together. We have to, this is, everyone, I mean, you know, especially radiation oncologists have to know about targeted agents. So how can we do some phase 1-2 study? This is where I want to pick your brain. I'm going to throw some ideas, but you guys tell me whether it's possible, because you are all in PARC, and you know, and COG, I'm using old word. I'm an old man. Okay, ablative radiotherapy as an in situ vaccine. What I mean, see, I give the example of sharpshooter versus throwing a grenade. Okay, so when you give ablative doses, it's like taking a small area of tumor and you are blasting it. So you produce new antigens, and the body's immune system suddenly wakes up. Oh my God, these are real foreign DNAs. And I mean, there are data, I'm not making it up. So I think that kind of thing can happen when you give a immunomodulation agent, a targeted agent, and very high dose radiotherapy to a small volume and explodes. So the shift from mutation-centric targeting in biology to biology-aligned strategies that include smart use of radiotherapy as another drug. See, this is not radiotherapy of old times. This is radiotherapy where we all work together to use as a new way of another additional drug. The exploiting the consequence of genomic instability rather than single drivers. So genomic instability can be smartly introduced by smart radiotherapy. So that's what I mean by radiobiotherapy. Beyond systemic drugs alone, rethinking precision as an integrated ecosystem level control. Because we popularized a word called precision population medicine. I'll show it in a second, okay? Because precision medicine is a lot more than genomic medicine. We often forget that. So locally recurrent osteosarcoma is where we can do phase 1-2 study, because there isn't much we can do. So you take those local recurrents, do chemo and SCBR and targeted agent, and then do the surgery, because that potentially can start the immune system to wake up and hopefully can improve the local control and distant mets. That's my hypothesis, 1, okay? Hypothesis 2, take metastatic, you have, let's say that we have 20 lesions. You take the big ones and you don't even have to treat the easily accessible one, away from heart, away from spinal cord. I mean, you know, we know how to do it. And then give them ablative doses. And then give the regular drugs, but use it as a immunomodulating extra drug. That's second hypothesis. And as I said, I already talked about locally recurrent. And then huge tumors, like my patient. We could have just, he was going to have amputation anyway, but you give a high dose, it's going to come out to a core of the tumor, let those new antigens go in, and that could have acted. What do we have to lose? That's another phase 1-2 study. So this is what we published this. What we meant by that, precision population medicine, is more than, I know it's very difficult to see. See, precision medicine to me is the right treatment at the right time for the right patient. It's not the right drug at the right time for the right patient. That's what we, most of the time we think. And that involves, this morning we heard about context by the general. The context is clinical practice, health organization, system context, legislation. This is a good meeting to talk about CAGLA. I mean, all these things have to be considered and to me, precision population medicine that will perfectly apply to Louisiana. So this is a figure we thought about where genomic medicine is important. EHR and related tools are important. Big data are important. This was published 7 years ago. But you also have all the other components so that we actually have a precision population medicine in our head. So I'm not going to read this paragraph. I just inserted this slide after I heard the 2 keynote speeches this morning. Because, see, there are some of the words that they used are very important here. Those are, see, genomic medicine, big data, EHR, telemedicine, smartphone, wearables. Not only that, interventions, but these should be in a manner that benefits from more inclusive definition, including lawmakers and academic places, because that's how we move the ball forwards. I'll stop there. I'll take questions. Summary. Victory is for the brave. Victory is for the innovators. Victory is for those who learn from their previous life experience, like this case report. Team science is better than solo science. Interdisciplinary collaboration are what is likely to succeed. We can learn something new from a remarkable young man who survived many hours due to all of the above. Thank you very much.